bladder cancer beyond BCG. This talk will go through several points which are enlisted here. The first one is the natural history of non-muscle invasive bladder cancer in relation to BCG response. And I'll go through some important definitions which pertain to the subject. And it's very important to understand these definitions because the literature of BCG and BCG failure and unresponsive and refractory disease uses different terminology that we have to understand very well in order to interpret those literature. The third point, I'll speak briefly about the fact that whether we can predict recurrence or progression after BCG therapy. Then I'll spend the major part of the presentation about the treatment options of BCG refractory or unresponsive or failure disease. Then I'll summarize at the end. So if we look into bladder cancer in general, 75% of the newly presenting bladder cancer is non-muscle invasive disease. This is the newly diagnosed patients. About 70% of those will have some sort of T1 disease or a low-risk disease. And the other 30% will have a high-risk, intermediate to high-risk disease using whatever criteria of risk stratification. Now, the important thing here is part of the 70% low-risk disease will basically have recurrence and in about 50 to 70, and 5% of those will progress from a low-risk category to a higher-risk disease. And in the other intermediate and high-risk disease, which are 30% of the newly diagnosed patients, are also important in terms of the high risk of recurrence, but more importantly, the high risk of progression. So the focus of BCG is the standard treatment for intermediate and high-risk disease, which is basically, if you add the numbers here, they're going to be around 40 to 50% of our non-muscle invasive bladder disease. Now, and this is the disease population that BCG is considered the standard of treatment. Now, if you look into BCG or the natural history of response to BCG, we can simply look into those and classify them into a 70% initial responder and 30% non-responder. So about 1/3 non-responder. And out of those non-responder, a majority will progress to a higher risk disease or even muscle invasive disease. And out of the responders, we have around 20% who will progress to a higher risk non-invasive or even a muscle invasive disease. So if you look into the BCG response, the overall response is about 50 to 60%, or in another way is about 30% of those patients will have BCG failure. And I'll come to this in the next slide. So if we talk in general, 40% of our non-muscle invasive disease population will have BCG failure at one stage. And this is a contemporary series where it looked into the rate of BCG failure in relation to time. So it's well known that most of the responders will maintain their response for 12 to 24 months. But if you look into the long term, and we know that non-muscle invasive bladder cancer is a long-term disease, the rate of failure will go higher, or the rate of non-responder will go higher with time. And this is really important when we treat those patients and consider their long-term response to the standard of care, which is BCG here. These are very important definitions, and we have to really understand those definitions when we deal with those type of patients. And we have really to understand these definitions when we read the literature of BCG in bladder cancer. Now, it's agreed upon that BCG failure is simply defined as the detection of muscle-invasive disease after BCG therapy. That is clear. Now, what about BCG refractory? This term is used interchangeably between different authors and between different clinicians. The most agreed upon definition of BCG refractory disease is the persistence of the same high-grade non-muscle invasive disease at 6 months of adequate BCG therapy. And adequate BCG therapy here means at least 5 doses of induction and at least 2 doses of maintenance. And the reason we used 6 months here will be explained in the next slide. But it's very important to understand that a refractory disease is considered, is defined as the persistence of the same disease criteria in this after 6 months. Now, BCG relapse, on the other hand, is defined as a recurrence of the same disease after a period of having a disease-free state. And a BCG intolerant, those who does not tolerate BCG from the get-go, from the start. So this definition is very important to understand and to differentiate different definitions. Now, why do we say 6 months? Because we know that beyond, there are some responders that it will take them 6 months or beyond to show response. Of course, this is in the absence of higher stage or higher grade progression. If we have the same disease grade and the same disease stage, less than 6 months, we have to wait before calling them a BCG refractory. Now, whether we can predict BCG response or not, many studies have been done in this regard, and they've used the usual disease stratification criteria that we use in non-muscle invasive bladder cancer, which are the grade, the number of tumor, the size, the presence and absence of carcinoma in situ, the multiplicity, and the recurrence within the first year or not. And the data here is really not consistent in terms of prediction of the response to BCG. We can clearly use these risk stratification criteria to predict the rate of recurrence and rate of progression, and to correctly stratify the disease category. But in terms of prediction of BCG response, it's not well established yet. And we don't have a perfect tool or criteria to predict who's going to respond to BCG and who's not. Before going through the options for beyond BCG, I have to really mention clearly that the standard of care for someone who does not respond to BCG, those are BCG failure, BCG refractory disease, BCG intolerant, or even BCG relapse. Any BCG refractory disease, the standard of care remains radical cystectomy, because radical cystectomy is the only option in those patient population that give more than 80% survival rate. So whatever option that I'm going to mention in my presentation from now on is not superior to radical cystectomy in BCG refractory disease. So we always have to entertain this option. We have always to discuss the pros and cons with our patient before jumping into one of the alternatives for BCG treatment. Now, this lists the different options that we have in BCG refractory disease, from secondary intravesical immunotherapy to different intravesical chemotherapy agent, to different device-assisted therapy, to novel products like gene therapy or vaccines or targeted or immunotherapy that I'll speak in details in the next 10 to 15 minutes. Briefly to mention the secondary intravesical immunotherapy, the well-known interferon in combination with BCG has shown some effect in those BCG refractory disease, also in patients who are BCG naive. And there is a large trial shown in this slide that showed BCG in addition to interferon alpha in those two disease two disease categories, BCG naive and BCG refractory disease, and it showed some response. And again, if you look into the Kaplan-Meier curve, you can appreciate that the majority of responder, they will maintain the response in the first 12 to 24 months, but then the response rate will always decline beyond the 12 to 18 month period. These results were validated in different disease categories, including those with carcinoma in situ. But again, it was noticed in a follow-up of those trials that beyond 24 months, the response rate declines to about 23%, which is somewhat half of the initial response in the first 12 months. And this applies to both BCG naive and BCG refractory patient. Now, when we look into mitomycin, so mitomycin is still an option, especially during the BCG shortage that we've suffered from in the last few years, and it's getting better now, but we'll still, in many places, we have BCG shortage. And some of the recommendations based on earlier reports, such as this one, that when you always induce with BCG induction course followed by maintenance, but if you cannot give maintenance BCG for any reason or another, whether it's shortage or intolerance, so don't forget that mitomycin has a place, and this is one of the earlier report that showed a response of intravesical mitomycin. Of course, it's not as good as BCG, but it's still an option. Now, different other chemotherapeutic agents were tested, like gemcitabine, like in a large trial, and gemcitabine was showed to have somewhat a response around 50% within the first 12 months, but again, it declines beyond the 12 month. And you can see from the Kaplan-Meier curve on the top here that the response was around 50% in the first 2 months, but as 12 months, sorry. But if you go beyond 12 months, it goes more than half down in terms of recurrence. Docetaxel, somewhat similar to gemcitabine. However, if you look into the combination or the sequential chemotherapy as shown in this study, by combining gemcitabine and docetaxel, whether in patients who are BCG naive or who had a single BCG failure or more than one BCG failure, there is some response that ranges between around 50% again in the first 12 months, but the response declines to around 30 to 34% beyond that, but it's still better than using a single intravesical chemotherapy. As you remember from the prior slide, it was around 20% beyond 12 months, but here you have around 34% when using a combination or a sequential intravesical chemotherapy with gemcitabine and docetaxel. Berubicin was the only FDA-approved intravesical agent for carcinoma in situ in those BCG refractory disease. Again, BCG, the standard of care is BCG. If it's refractory, we should, as I mentioned before, cystectomy is the standard of care, but we still have an option in those who are not candidate for cystectomy or those who are refusing cystectomy with carcinoma in situ only disease. Berubicin is an option, and I'll come to other newer options in later on. So the prior chemotherapy is without using any device-assisted techniques. In the recent decade, there were enthusiasm regarding using different drug delivery modalities. whether Urogen, Dr. Baghdadi here will give a talk about using one of those modality in upper tract urothelial cell carcinoma, but it was tried in the bladder. Another technique which is developed by Taris, which is called the Britzel technique. There is two other techniques which are available in the kingdom, which is the high intravesical hyperthermic, or the combat, which is heating the chemotherapy before injecting it into the bladder, or the electromotive drug-induced delivery. And I'll share with you some data regarding some of those device-assisted therapy. One of them is the thermochemotherapy, or the HIVIC, similar to the HIVIC used by our colleague in surgical oncology. The HIVIC is basically a technology that heats the chemotherapy, which is mitomycin in this cases, to 40 degrees centigrade before, and circulating the heated chemotherapy while it goes into the bladder. And the theory behind this is that the heated chemotherapy will increase the absorption and increase the efficacy with potentially lower side effects. And this is a forest plot of 4 different trials that showed some response to this technique. However, I mean, those trials were relatively small. The follow-up was relatively shorter than what we used to see in those patients, and still waiting for larger size trial with longer follow-up, examining the value of this technique in those type of patients. The other technology, which is the electromotive drug administration, similar concept. It's using an electrodes that are put in the lower abdomen, and the third electrode is through the Foley catheter, and then it delivers the chemotherapy, which is mitomycin here, using an electrical signal to increase the absorption. There were a Spanish group that published on this technique, and their publication, actually, they used a comparison of using this technique with mitomycin compared to mitomycin alone, as we use it, compared to BCG in treatment-naive patients. So they did not use the BCG refractory patient. They have an intermediate and high-risk disease population, and they randomized them into 3 arms, and they've tested this technique, and they're 2 years. They have 2 years data, and the results showed a similar response to BCG alone. But here, this study was also compared the efficacy of BCG to the EMDA, which is the electromotive with mitomycin, and the results were similar. But again, this trial was relatively small, and it was never validated. So this was a systematic review of all these device-assisted therapy. They are promising techniques. The trials are smaller, and the follow-up is not as we like to see in those type of patients. So the bottom line of those the device-assisted therapy, that they are promising, but we need a more robust data in order to utilize them and use them in our daily practice, and again in BCG refractory disease for those patients who are not candidate or refusing cystectomy. Photodynamic therapy in the late 90s, there was a huge enthusiasm for photodynamic therapy using different agents like the 5-ALA or another newer agent like the hexaminolevulinate. But again, those were small trials, and the side effects of those photodynamic therapy was huge in terms of cardiotoxicity, phototoxicity, and other major side effects. So people were shying away from photodynamic therapy until recently. Another photodynamic therapy passed clinical phase 1 and 2 trial using a safer agent called ritherine, and there is a clinical phase 3 trial which is still enrolling right now based on the phase 1 and 2 trials, which showed a good response and a good tolerability with negligible side effects. And basically, it's based on the same concept of the older photodynamic therapy, where the cancer cell absorbed this material, and then using a green light laser, it will destroy those cancer cells. And there is, as I mentioned, the clinical phase 2 trial is completed, and now they're doing clinical phase 3 trial. And here, the trial was designed to compare them to BCG failure, not like the electromotive and the hyperthermia, where they used them in the BCG naive, which is again another plus point for this trial, and we're waiting for the results. Now, the last part of this talk is going to be about the newer modalities, which are the vaccine, the gene, and the immunotherapy. And the field here is really very encouraging. There are many trials that have been presented and published recently. Vaccine therapy, basically, there was a clinical phase 2 trial using the HS410 vaccine, and it was used in comparison to BCG alone, or it was used with high dose plus BCG and low dose plus BCG. Again, BCG alone showed superiority here, but we still waiting for the phase 3 to see the HS410 long-term effect in terms of BCG refractory disease. So this is one of the vaccines that are promising. The CG0070 is a gene therapy, whereas basically they published a clinical phase 2 trial about this gene therapy, and the results are shown here, where the phase 2 trial showed an encouraging overall response of 30%, again in the first 12 months in all comers. But when we look at carcinoma in situ alone, it was around 25% in the first 12 months. And it is a promising modality of treatment. Still, this was a clinical phase 2 trial, and we're waiting for the phase 3 results. Another gene therapy, which is very encouraging, the phase 3 results were presented last December. That was 6 months ago in SUO. This is basically a virus that it's injected through the bladder. It promotes the bladder wall to produce their own interferon, which can help in destructing the cancer cell and preventing further recurrence or progression. It's developed by Ferring, and these are the data that were presented in the SUO in December 2019, and the 12 months response rate, both in carcinoma in situ disease and other high-risk papillary disease, were encouraging. And we're waiting for the full publication. And I believe this is one of the first gene therapy. It's called FerGene, developed by Ferring, that will be seen in clinical practice soon. Another also gene therapy is being studied, the BC819. There are still clinical phase 2 is being conducted, and we are waiting for the results. So out of the 4 gene therapy that I discussed, the Ferring gene therapy is the one most likely to see clinical practice soon. Targeted therapy, Vicinium is one of the targeted therapy that showed an effect on BCG refractory disease. It's basically an anti-EBCAM that is attached to a Pseudomonas toxin, and it's given through the bladder, and also it showed the complete response rate with about 15% within 12 months in phase 2 trial Phase 3 trial is going to be out soon, and we will see how is this targeted therapy in comparison to the standard of care soon, and we may also have this available in clinical practice sooner. These are the registration results. The as I said, the complete response was 15%, and in carcinoma in situ subset, it was 42% recurrence-free rate of with Vicinium. Immunotherapy, BCG is the oldest immunotherapy that we are using in non-muscle invasive cancer. And from the studies that were done looking into the effect of BCG, it was well shown that the BD1, BDL1, and BD1 has a role in the treatment or pathophysiology of bladder cancer and the treatment. So this encouraged researcher to look into oral immunotherapy in the non-muscle invasive disease. And again, this is one of the area that is basically showing a great progression in terms of results. That the Keynote 057, which examined it was a phase 3 pembrolizumab given orally in BCG unresponsive carcinoma in situ. And if you remember that in the slide where Vilrubicin was discussed as intravesical chemotherapy, it was the only FDA-approved option for BCG refractory. But pembrolizumab orally was recently approved by FDA based on this trial as an option for BCG unresponsive carcinoma in situ. And these were the results. They were presented in ASCO GU last November 2019, where it showed a response rate of around 41%, which is one of the best response rate in BCG refractory disease among all the agents that we discussed previously. And the response rate was durable for up to 16 months, which is again not as the other modalities that we discussed previously. So this is a promising option for BCG refractory. And another study that is still ongoing, which is using again pembrolizumab, but in combination with BCG. The Keynote 057 used only pembrolizumab in comparison to BCG, second induction of BCG refractory disease. But the Keynote 676 is examining a combination BCG refractory patient randomized into pembrolizumab plus BCG versus BCG as a second induction. And again, we're waiting eagerly for the results of pembrolizumab. And I think based on the Keynote 057, this result this trial will show positive results. This slide also shows the other immunotherapy that are being studied in non-muscle invasive disease. And as you can see, there are about 10 trials ongoing with different checkpoint inhibitors in this field. So I believe that the non-muscle invasive bladder cancer that has been in the shadows for 30, 40 years with very limited option is finally seeing the lights here with a lot of options to treat and spare those patients cystectomy, hopefully in the near future. So in summary, non-muscle invasive bladder cancer refractory BCG treatment, the standard of care is still radical cystectomy. But in those patients who are refusing radical cystectomy or not a candidate for radical cystectomy, we have many options, whether intravesical chemotherapy alone or with the device-assisted techniques or with the newly approved pembrolizumab or even the pre-gene therapy. The future perspectives are very promising. Thank you very much. So would you like to leave the question till the end?
الو
تفضل يا
الو
محمد.
It's my turn. Yeah. Thank you. Do you hear me?
تفضل يا محمد.
Okay.
Yes, we can hear you very well.
Okay. First of all, I'd like to thank you, dear colleague, and you make my life is difficult, Dr. Sultan, after this an extraordinary lectures, honestly. Just I try to try hard to just imitate what you present now. It is excellent. Actually, I'm going to talk about one of the rarest subjects in the all of urology, and had been neglected for so many years, actually, for so many reasons. One of this reason is very rare because the rarity of the disease. The better we understand, the better I'm not going to hit immediately to treat like, or to explain the new adjuvant chemotherapy before we head to explain the disease. Because with the better we know the disease, the better we treat this disease as the single identity. For years and years that we thought the upper TCC as the single or the identical twins of the bladder cancers. So I'll give a very quick review. I'm going to introduction on pathogenesis and epidemiology, current standard of care, the surgical principle, discuss of the impact of renal functions, and then the new data in genomic and the preoperative chemotherapy and the risk adapt treatment algorithm. I wouldn't take a lot of time to explain this, but to give an overview to understand better the upper TCC. As we know, the upper TCC, the urothelial cancer, it's considered the fourth common cancers among the men. Actually, it's 90% in the bladder cancers, of 5 to 10% of all in upper TCC. The prevalence is more in men, 2 to 1, and the age of the group age, it's like from 60 to 70. These cancers are concurrent of the bladder cancer around 17% with the bladder cancers. The microbiologists, as I said, for years and years, we are extrapolating the data from the bladder cancer to upper TCC. Whether this disease is the same like a bladder cancers, most of our junior and even the junior consultant and the general practitioner and urologist, they think it's the same disease. The investigator, they dig in the genetic a lot, and they explain it's the second cousins. The bladder cancers and the upper TCC. The upper TCC, it looked like the main take-home message that the upper TCC, it looked like a laminal papillary of the bladder cancer. However, there are a lot of different. Now we are starting receiving data from the genetics expert researchers that we have like unmutated FGFR3 more mutated in the upper TCC, especially in high grade, while in the bladder cancer, the gene mutated more in B53. This is the high genes mutated. It's look like it's increasing in the upper TCC. The FGFR more mutated in the upper TCC high grade, while TP53 more mutated in the bladder cancers. The upper TCC, it's look like a second cousins that result secondary bladder cancer often share the same mutations. Sign and symptom, unfortunately, most of the upper TCC, when they present to your clinic, they presenting with the invasion around 60%, 60 to 65, while in the bladder cancers around 25 high grade. Most of the patients arrive with the or the sign of the 70 to 80% with the hematuria. Some of them they have a flank pain. If we reach to if a patient you saw the patient with anorexia and fatigue, definitely you have to think about the metastasis cancers. This is I'm pretty sure that most of the audience, they know the epidemiology and etiology. More of the risk factors they share with or they have the same risk factor like bladder cancers, with the few special identity or the special risk factor like Balkan nephropathy and hereditary disease. How to diagnose the upper TCC? We rely on the European guideline. The gold standard is the CT urograms. My practice, I use the combination between the both ureteroscopy and the CT scan to give a proper or to differentiate the histological correlations to give a better histopathological stage since we face a lot of problems with the staging in the upper TCC. CT urogram is the best way to identify the upper TCC with the diagnosis by ureteroscopy. Clinical staging, this is one of the obstacles we face in the upper TCC actually. The clinical staging almost irrelevant and difficult to diagnose a patient or taking him to OR on the clinical staging. Actually, we rely more on the pathological stage and biopsy from ureteroscopy. So the take-home message, the grade is surrogating for stage in upper TCC, high grade is bad. This risk adapt management to triage the patient, whether it's low risk or high risk. In the low risk, Dr. AboSamra is going to talk about the low risk and the treatment. I'm going to concentrate mainly on the high risk. High risk upper TCC, usually you don't find the patient with the high risk with the hydronephrosis, the tumor size more than 2 centimeters, high grade of cytology, high grade, the multifocality. But my take-home message in this slide: do not let the treatment or push the envelope treatment, the low risk, away from the curable window. If the patient he had a recurrence in the low risk, you have to treat him as a high risk as the radical nephrouretrectomy. So the high grade, high risk, gold standard nephrouretrectomy. Here's some of recommendation of the level of evidence. All of the high risk group, the high risk disease in the upper TCC, we should do radical nephrouretrectomy with the excellent cuff excisions. These trials depend on the flexible ureteroscopy. We take biopsy, and now we have a rule of the systemic review, either neoadjuvant chemotherapy or adjuvant chemotherapy. As I said, do not let the treatment of the low risk take you away to lose the window of curability in this such aggressive disease. Here in this scheme is pretty complicated, but you have to know the mid-proximal ureters and mid and proximal ureter, you have to treat it as the by nephrouretrectomy, as the nephrouretrectomy. The mid ureters, there is a room for ureterectomy with the preoperative chemotherapy. However, if the patient, the judgment is left for you if there is a lymph node and you can do nephrouretrectomy, or if the patient he has advanced disease. So the lymphadenectomy, now we have a rule for lymphadenectomy. So many researchers and articles show that the RBLND, we call it RBLND because the template is look like similarity like the testicular cancers. Most of the researchers like Surana Matan, that he has a big field in the upper TCC, recommend, and Kondo, he has some article from Japan. The best to resect an 8-node, the template is matters and important. Why we remove the lymph node? So many articles or a lot of articles show there is upstagings after understaging. Sorry, after we take nephrouretrectomy or lymphadenectomy, we show that they study 151 patients with the T here. It's not a pathological, it's T0. After the radical nephrectomy, nephrouretrectomy with the lymph node, it showed that it's upstaging to 13%. This is another study from Kondo, from Japan. It showed that the better you do RBLND, the better low recurrence or no recurrence locally. This is the template. Suggested that there is a lot of template now. There is a modify, but it's exactly the same, like more or less like testicular cancers. Sorry. More than like a testicular cancer, you have to start in the right side, you dissect and you take a paracaval, retroaortic cables, and in the right side, to dissect, to reach all of and dissect all of the node, you have to go intra-aortic cable. However, in the left side is the difference. If you start on hilers and para-aortics enough, the things that they add on the Kondo study and Matan is the lower ureters. If we have a mid ureters, we dissect. If you have a mid ureter, we dissect common iliac and we go to para-aortic cave and retrocaval. If we have a lower ureter less than the level of the common iliac, we have to go the templates and dissect all of the pelvic lymph node. Now the lymphadenectomy is recommended, very strong, recommended in so many guidelines. Actually, we done the lymphadenectomy, and now I have to emphasize on the bladder cuff excision or resections. We have three procedures, either extravesical, intravesical, or endoscopy. Do whatever is suitable for you, or even radical nephrectomy, doesn't matter, robotically and laparoscopically or open. But some study that showed in the laparoscopic group that they showed they don't use the staplers. It is increased the bladder recurrence. And now we have two randomized study to decrease the bladder recurrence, one from England and one from Japan. Both of them, they have a very excellent at 1 year's free bladder recurrence. One of them 27 and the other one is around 35. Nowadays we use the gemcitabine because instead of the mitomycin for two reasons. Because nowadays we use the intravesical injection inside the OR while we are doing the radical nephrectomy. We ask the anesthetist to decrease the fluid. We empty the bladder, insert the catheter, and we give intravesical the gemcitabine for 2 hours until we reach to the bladder cuff, and then we empty the bladder, and the same result as effect as the other study. If you the take home message, if you need to do a nephrectomy, do it full surgery, remove the bladder cuff in such way to prevent the bladder recurrence and remove the node. The follow-up nephrectomy, same, especially for high risk, is the same as the bladder cancers. Follow-up cystoscopy, cytology every 3 months for a period of 2 years, and then every 6 months for the 5 years until and then yearly. Now as I said before, our TCC has been neglected for so many years, for so many reasons. We extrapolating the data from the bladder cancer to our TCC. We are lack from excellent and evidence of the clinical prospective trial. Nowadays, we have a data prospective clinical trials. We have also for the first time for our TCC, the level evidence prospective random trial study has been done, called POUT. So the window is now open. So many running prospective trial it showed, but still there is obstacles. Numerically, the upper TCC response to the chemotherapy is not much as the lower as the bladder cancer for so many reasons. Either this reason here is like we found here the 38 response in the bladder cancers. They depend on the level 1 bladder cancer cisplatin trials, and in the upper TCC, unfortunately, we have like numerically is lower than the bladder cancers. The questions here: does the both disease morphologically and histopathologically and genetically is totally is different, a bit different? They are not cousin even. Or the major rule that has been studied in so many literature that the debulking of the resection, it's make the cisplatin more effective in the bladder cancers. This is the meta-analysis that has been done 2014 for so many retrospective study. Most of them retrospective study found the benefit disease-specific survivals with the statistically approved. And this have been updated, revealed another retrospective study. It showed the higher probability of the pathological down stage in control group, which underwent to surgery alone. So this is a good study. Some of them retrospective, some of them prospective. I'll take this one, MVAC accelerated, because I'll explain it later on. Just a 29 patient, they found the pathological response is 14%. But the things here is that 62% the down stage, either 2-0 or 2-1. That's a good result. And accelerated, in fact, now in combination of the target therapy, it reached downstage to 75%. Some data on some ongoing phase trial 2 and 3. One of them is good from the MD Anderson. It has been presented last year. It shows very good data. It's single arms. They use gemcitabine with the cisplatin eligible patient. It showed very good result in overall survival. Comparing to in the other series, they do it just for once a single arm. It showed that it's a promising result and the promising outcome. This is something. This is very good study has been presented in the EUA 2018 phase 2 trials, and then they are going to phase 3 trial echoecrin 8141. They divide the patient according to the renal functions, if the AGFR more than 50 or if GR less from 30 to 50. Accelerated IMVAC, and the other arms is gemcitabine with the carboplatin. The result also showed the complete response is like 14, and the down stage to most of the patient is T1 or T0. The good things and good news, 80% of those patients all receive all of the cycle of MVAC with this such a good result. MVAC is safe and well tolerated. They continue to now in the phase trial 3 to look at the endpoint. All of this trial has been going, and the still we're waiting for the result. Now, most of the retrospective study and prospective study speaking, or they have an end result down staging of pathological. This article just last month, does the pathological stage surrogated for early oncological outcome. It's very nice from Texas University and MD Anderson and Memorial Sloan Kettering. They take a two patient, the two arm. The patient who high stage receive neoadjuvant chemotherapy and down stage to non-muscle invasive T0 and T1, T0, TA, T1, and they compare it with the low grade T1, T0 and T1 patient who didn't receive the chemotherapy. The result, they show the outcome, oncological outcome, is the same and even much better for the patient with the pathological outcome, despite the statistically not significant much, but this disease, when downstage, it compared though the inherited, if we compare to the low-grade non-muscle invasive originally. So we have a good result like the pathological endpoint. It could rely as the early pathological outcome. Consider neoadjuvant chemotherapy. We have to think about future. We have very good data. Before I leave, I have to speak about the adjuvant chemotherapy. We have an excellent data called POWER. This is the first ever randomized trial study. This study, it's opened the window and open for us a window of hope to use the chemotherapy in upper TCC. This study is randomized study. One group for chemotherapy, they use like the control arms, and the other group, they divided for GFR, one group cisplatin. Both of them, they received gemcitabine with the carboplatin or cisplatin. The end result, the disease-free survival is 71% in the patient with the chemotherapy, while in surveillance is 54%. The difference is around 20%, which is something is good. We have to look at it and we start to change our way of treatment of this mysterious disease. Just as a big questions between the chemotherapy alcohol, whether neoadjuvant, whether adjuvant. Actually, I'm with the neoadjuvant chemotherapy, and the people they investigate POWER, or the people who did POWER, they answered the question. We have to go to, when they did the multivariant group, they answer your question. In the multivariant group is different. The response to chemotherapy is different between a group and group. While in the N0 is much better than in N positive, N1 or N2. And also we have a big bunch of patients, they receive gemcitabine with the carboplatin, and the carboplatin, we don't know, the author of this article, they didn't emphasize, they didn't elaborate it much, the gemcitabine with carboplatin. There is no effect of carboplatin. So why we use carboplatin here? Because we have ineligible patient. that their renal totally deteriorated after the nephrectomy. So they answer our question, whether neoadjuvant chemotherapy, gemcitabine and the carboplatin, they are around 96. They didn't get an overall benefit from the chemotherapy. And also in a microscopic margin status, as we know, the neoadjuvant chemotherapy, it decreased the margin of the margin after nephrectomy. So they answer our questions, whether we neoadjuvant or the adjuvant. No, we will go with adjuvant chemotherapy. Conclude the take-home message: adjuvant chemotherapy should be considered for anyone that not get non-adjuvant chemotherapy. Now they answer the question. Most of the patients, when they arrive for the diagnosis of the upper TCC, they lose 50% from the renal functions, and after surgery they lost around 2/3, 26 and 2/3 from the renal function. So they lost the eligibility for cisplatin. This is all of the question: which way we go with staging challenge? Yes, because armamentariums of the new armamentarium, the armamentarium that the adjuvant group hide behind it. First of all, the overstaging. They say overstaging is a matter, but in MD Anderson's, they collecting group from 1993 until 2006, and they found that there is 35 to 40% is upstagings. It's not understaging, and this is one of the answers. And this is the big answer. So the questions here, whether the upstaging, no. Treatment, the early treatment of the micrometastasis, yes, in the neoadjuvant chemotherapy. And all of these things, take all of the oncological impact and outcome, to lose the eligibility is much higher in the adjuvant chemotherapy than the neoadjuvant chemotherapy. Thank you. This is very excellent non-systemic meta-analysis. It gives you all of the updates. It's just recently published. It gives you from scratch to Z in all of the matter of the upper TCC. Thank you so much. Hello?
Stop sharing.
Okay. I can hear you.
Stop sharing. And I will start sharing mine. Yeah. Do you see my screen?
Yes, it's clear.
Okay, excellent. Assalamu alaikum. Hi, colleagues. Excellent presentation by both of my colleagues that made my presentation look silly. However, I'll try to lure you to do nephron sparing management for upper tract urothelial carcinoma, and I'll explain why. So the problem that unfortunately among the age demographic that at risk for upper tract urothelial carcinoma, which is usually around the age of 65 to 70, up to 50% already demonstrate chronic kidney disease, stage 3 or higher. Upper tract urothelial carcinoma undergo radical nephrectomy as primary treatment. So radical nephrectomy is associated with about 25 to 30% decline in estimated GFR. And this decline may be even greater in those with pre-existing chronic kidney disease, stage 3 or higher. And if we look at the life expectancy of a 55-year-old male patient, his expected life expectancy is about 25 years. Patients with transplants, 15 years. Patients on dialysis is only 5 years. So the median life expectancy for a 55-year-old that goes into dialysis is only 5 years. So imagine it for somebody who's in 65 or 75 years old. And this is the sub-analysis from one of the studies that did a palliative resection for patients with solitary kidney with high-grade disease.
Ashraf, the quality of sound is not good.
That didn't undergo so quality of sound. Samani? At 2 years, 64%, and at 5 years, 33%. So their survival rates on dialysis for this patient population is only 33% if they undergo radical nephrouretrectomy. So radical nephrouretrectomy with bladder cuff, it's the gold standard. However, it is a moderate risk procedure in higher risk population. It reduces the renal function and it limits the eligibility for future platinum-based chemo. The endoscopic resection is usually reserved for imperative indications or small low-grade unifocal tumors. Should endoscopic management be extended to a broader group with resectable disease? So the imperative indications for kidney-sparing surgery is the anatomic or functional solitary kidney, substantial renal insufficiency, bilateral urothelial carcinoma in the upper tracts, and surgically comorbid patients that are ineligible for surgery. However, there is those elective indications that we think that we should extend the nephron-sparing options to, which are all lower risk upper tract urothelial carcinoma, highly selected high risk upper tract urothelial carcinoma, like patients that might be multifocal or large tumors with low grade and superficial features, and they must be follow-up compliant. So who are those low risk upper tract urothelial carcinoma? Those are patients with unifocal disease, tumor size less than 2 centimeters, low grade on cytology and on biopsy with ureteroscopy, and non-invasive on CT urograms. The higher risk patients are the patients that present with hydronephrosis, larger tumors, higher grade on cytology or biopsy, multifocal disease, previous radical cystectomy for bladder cancer, and patients with variant histology. However, there is multiple diagnostic obstacles, like the lack of early symptoms. These patients present very late in disease because of the larger size of the renal pelvis, usually, which is about 2/3 of upper tract urothelial carcinoma happen in them. It can take a bulky tumor without causing any local symptoms. The limitations of radiographic diagnostic tests, especially for small luminal tumors, the complexities and variations in upper tract anatomy, the need for multiple forms of evaluation to confirm the diagnosis, and the poor predictive value of biopsy to assess grade and stage if we don't do it properly, and the need to map the extent of the disease within single or maybe both kidneys, and the absence of comprehensive treatment strategies and guidelines. So CT urogram suggests the possibility of a tumor in the ureter, but it's not diagnostic. So there must be a role for ureteroscopy and maybe other forms of imaging. And is white light ureteroscopy good enough? So other forms, the CT urography has high sensitivity, high specificity. It's good enough. Even the MRU is not as good. IVP is not as good. The retrograde parallelograms do as a good job as the CT urography. However, the CT urogram pitfalls is that sensitivity decreases with smaller lesions. 89% for lesions that are less than 5 millimeter, but it's only 40% for lesions 3 millimeter or less. And it doesn't distinguish between benign and malignant lesions. However, when we look at the CT urograms, if we look at the normal windows, the abdominal windows that we look at, we see this. However, if we look at the bone windows, we can see better the filling defects in the CT urograms. So if we look at the late phase of the CT scans, the delayed images, look in the abdominal and the bone window to see those filling defects in a better way. And now we have, with the ureteroscopies, the poor vision that we used to with the fiber optic has much improved using the digital ureteroscopes and the disposable ureteroscopes. The difference in the image is huge. So better vision is better diagnosis. And with that diagnosis, we can tell the differential between these benign conditions like fibroepithelial polyps and papillary necrosis, and the real tumors, like here, this multifocal disease. And cytology can help us a lot, especially that the cytology, if it is positive, is highly suggestive of upper tract urothelial carcinoma when cystoscopy is normal. However, its high false positive rate in low-grade diseases up to 50%, but it can detect higher grade tumors easily. The other problem is the small size of the biopsy, the limited tissue obtained in biopsy. This is the size of the tissue that you can take with a 3 French cold cup. This is what can fit in the ureteroscopes. However, if we look at the 6 French biopsy from Cook, or when we use the zero-tip nitinol baskets for polypoid tumors, we can have such big tissue that will be enough for our pathologist, not to say that it's quite difficult to determine the grade or even the stage in such very small, tiny piece of tissue. So the biopsy can accurately grade 82% of urothelial carcinomas in the upper tract. Even with that, 17% get upgraded at final pathology. It understages, however, in 54% of patients. So the grade is very important, and to risk stratify patients rather than grade. To improve the vision, we can use other than the white light cystoscopy or in the bladder, like the PDD, which can also be used in the upper tract. However, with narrowband imaging that's readily available and doesn't need injection of any material, with the Olympus cameras, you can see much better images with the narrowband imaging. As you can see here in the left side images, you can see these small polyps. If you turn on the narrowband imaging, you will see that this is only because of the irritation of double J, for example. However, the same look exactly when you turn on the narrowband imaging and you see this frog egg effect, those small nuclei in the you can see them. This is diagnostic of a urothelial carcinoma. And if you see here in the bladder, when you turn on the narrowband imaging, you can see also that there is a lack of the frog leg. And it was studied, and it shows optimal limit for resections. It can differentiate between normal-looking tumor, abnormal-looking benign from tumors, and it can show exactly what is the borders that of that tumor. Also, to improve the vision even more and more, there is the percutaneous approach, which can be utilized for larger tumors. And you can use the resectoscope to resect such larger tumor. However, usually the resection part is only for the base, because you don't want to destroy the tissues with the heat effect and cautery effect. If you are afraid of the tract seeding because of the percutaneous approach, this is very rare. In this series from Arthur Smith, one renal unit out of 133 that had percutaneous approach developed tract seeding, and it was treated with local excision and radiotherapy, and follow-up at 2 years, there was no recurrence. And is that how nephron sparing approach effective? All of these articles have looked at that, and there was this meta-analysis, and it showed that the cancer-specific survival of endoscopic management is equal to radical nephrectomy. It was not as good for overall survival, but there's a catch. These are all comers, not only low grade, even some high grades. And if you look, what made the lower 5-year overall survival, it was the high grade disease managed with endoscopic resection. Despite that, the 5-year cancer-specific survival there was no difference between low grade and high grade and the radical nephrectomy. And you can see that the local recurrence, the kidney is there, you didn't remove it. So there is some local recurrences, about between 12 and 71%. And in the radical nephrectomy, there is a recurrence also between 1 and 18%. The bladder recurrences are almost the same between patients that underwent endoscopic resection versus the radical nephrectomy. So despite that, the diseased renal unit are still there, there was no lower tract seeding more than the radical nephrectomy patients. And this review looked at the oncologic outcomes, and the most important thing that 80% of the kidneys that underwent endoscopic management had their kidney spared at about 5 years. And that's very important. So we saved 80% of the kidneys, and we saved 80% of the patients from going into dialysis. The take-home message here that there should be proper patient selection, low grade, mostly no invasion on radiological images, surgically manageable, it's resectable disease, and the most important that the patient should be and must be follow-up compliant. Understand the diagnostic limitation, choose your weapon wisely. Some people can be treated with ureteroscopes, others with a percutaneous approach. However, it has comparable outcomes to radical nephrectomy for proper candidates with high rate of kidney sparing. What about adjuvant treatment? The obstacles with adjuvant treatment is that the administration of the BCG in the upper tract has been described by slow gravity with the percutaneous nephrostomies, or retrograde via cystoscopy and ureteric catheters. However, there was also description of far less reliable methods that depended on the reflux that happens in the kidneys if you leave a double J stent. However, this we will see that it's not as good. Each of these methods is inadequate due to lack of the dwelling time. The chemotherapy, the longer that it stays, the better its effect. There is uneven topical distribution in the renal calyces, pelvis, and the ureter. Some areas can get the chemotherapy, some areas couldn't. Higher risk of infection and systemic absorption compared with the bladder administration, and centurion production, making inadequate dosing difficult because of the constant dilution and gravity taking the chemotherapy down to the bladder. Mostly we use BCG for a higher grade, but those patients are very, very rare. We stopped using mitomycin. Now we are using gemcitabine. The results from the BCG are good, 81% response rate, whatever that you use it, antigradely or retrogradely. And this is with mitomycin. There is also a very good response rates, and the recurrence rates is around 40%. And adjuvant treatments is 6 weeks enough. There should be a maintenance for patients with high risk. I think maintenance is good. Methods of delivery: when they compared the nephrostomy tubes to double J's to ureteric catheter, the best was with the ureteric catheters. The areas that were reached was the best with the ureteric catheters. It reached everywhere in the kidney, upper poles, lower poles, mid-calyces, renal pelvis, mid-ureter, distal ureter. It reached everywhere. So please use ureteric catheters if you gonna give chemotherapy or even BCG. Now we come to a very new FDA-approved drug, which is called Matigel. The Matigel is a polymer that has inverse thermosensitivity. So it is solid at body temperature, but it is liquid at low temperature. So it is stored in low temperature. It's injected in the ureteric catheters into the renal pelvis, and then it's solidified there. It has 4 milligrams of mitomycin C per 1 ml of gel. Each of those vials has 15 cc's. So you need to measure first how much the renal pelvis will take with to distend adequately without extravasation, and then give that amount into the renal pelvis. It comes with an injector and a syringe housing, and this syringe with Matigel. And it was tried before in compassionate use program, and there was 22 patients enrolled. 14 completed the treatment. So 8 of them out of these 14 had complete response. 3 had recurrences, and 4 of the patients that had complete recurrence had complete recurrence more than 1 year. So that yielded to the Olympus trial. The Olympus trial had patients given weekly doses for 6 weeks, and then there was a primary diagnostic evaluation, so another urethropscopy, and then follow-ups at 3, 6, 9, and 12 months. And they looked at patients with low-grade upper tract urothelial carcinoma. The protocol was they measured the renal pelvis and calyx volume, as I told you. They gave alkalinizing sodium bicarb in the evening before and the morning of, and 30 minutes before the treatment to alkalinize the urine. So the mitomycin will have better action. And the targets were, they enrolled 74 patients. And those patients had tumors that are between the size of 0.5 to 1.5 centimeter, so they can assess the action and the efficacy of the mitomycin gel. as I told you, and they even allowed patients that had larger tumors to be resected first and then be enrolled. They only took patients that have tumors superior to uretropelvic junction. They excluded patients with CIS or high-grade papillary or had BCG in the last 6 months. So 60% had complete response in the primary disease evaluation at 3 months. And the durability of that complete response, that's the absence of the tumor. And all of these patients had a tumor between 0.5 and 1.5 centimeters. 13 of those 20 had complete response for 3 months, 4 had for 6 months, and 1 for 9 months. The partial response was 14%. About a quarter of the patients had no response. What are the side effects? 40% had a flank pain. About another 40% had ureteric events, and the ureteric events are hydronephrosis, strictures, stenosis, obstruction, and narrowing. The nausea and vomiting happened in 35%, lots in 35%. Renal events, which included creatinine increase, hyperkalemia, and renal function decrease, happened, and immune reactions, weakness, fatigue, hematuria, and a UTI, 23%. So it appears to be safe, the Mitogel, and well tolerated. It's feasible with retrograde installation, and the adverse event profile appears to be acceptable. The interim data suggests primary chemoablation is possible, and durability of complete response require for a longer follow-up. Other future like things can be with drug-eluting balloons, and this had been used ex vivo and in vivo in animals, and it showed that because of the slower eluting chemotherapy, for 12 hours they could detect the paclitaxel in the urothelium, submucosal, and muscle layers, and even up to 24 hours they can detect that. Other way is drug-eluting ureteric stents, still in works. How do we follow these patients? We follow them 3 months for the first year, and then every 6 months for 2 years, and then every year thereafter. And periodic upper tract imaging, they should have a CT urogram every 2 years. It had been included in the most recent NCCN guidelines that for low-grade disease in renal pelvis, endoscopic resection with post-surgical intrapelvic chemotherapy or BCG is an option. Even for urothelial carcinoma of the ureter, upper ureter, endoscopic resection is good for with any grade. For low-grade disease in the mid-ureter, also excision and ureterostomy can be done, and endoscopic resection can be done. For distal ureters, distal uretrectomy is a form also of nephron-sparing surgery. It can be done for low grade or high grade. If we are doing low grade, endoscopic resection is good enough. If it is bulky, distal uretrectomy can be done. However, if we are doing distal uretrectomy for high grade disease, regional lymphadenectomy should be done, and reimplantation of the ureter should be done, and new adjuvant chemotherapy also should be considered to decrease the volume and the chance of the positive margin in such patients. Thanks a lot. So the floor is actually open for questions. Okay, so this is a question to Mohammed regarding neoadjuvant chemotherapy. how long do you need to wait before nephro-U, and is there a risk for delaying the treatment? From Ahmed Zahrani. Mohammed?
Hello?
Aywa. Question?
Actually, it's excellent questions. All of the literatures that have been reviewed, all of the literatures, since they emerge or they since appear of the retrospective, prospective, and even clinical trial, the prospective, there is no one, this is the, no one single patient has been progressed. All of the patient, there is no progressions in all of the literatures. You cannot find even single one patients. And usually neoadjuvant chemotherapy, I would treat the like a bladder cancer exactly. After the chemotherapy from 5 to 6 weeks.
Yeah, even you can wait even for up to 12 weeks, but usually 4 to 6 weeks.
I do it as 4 to 6 weeks. It's good enough. And this is what the actually the people that they provide POUT, they ask one of their argument against the neoadjuvant chemotherapy, the progressions. But I assure you, there is no one single patient progress in all of the neoadjuvant trial, either retrospective or prospective. But you have a window until 12 weeks to do the nephroutectomy, but you have also, you can do it 6 weeks after the neoadjuvant chemotherapy.
Okay, so and the other question is for me. So thank you, Ahmed, for your compliment. In your practice, how frequent do you go for kidney sparing surgery? And what are the main obstacles in your opinion? I do it for low grades. The problem when it is too bulky and in areas that are very difficult to reach. So if we have it, if I have a tumor more than 3 centimeters, it's quite difficult. But now that I can partially resect and then give mitogel, that's good, because it had shown that it can ablate tumors completely in 60%, and there's partial response in about another 15%, so that's 75%. The other problem is that I think that the biopsy, the inadequacy of biopsy. So for tumors that I can take with a basket, it's great, but unfortunately, big biopsy is not always available to take a larger biopsies. There is others in the chat, I believe. Doctor, I think there's a question for Dr. Khateeb. Can we use BCG in organ transplant patients? Sultan?
Yes. So the concern of immunosuppression with in relation to BCG is there. It is a relative contraindication. So if you have other options, you should consider. However, it is contraindicated usually in immunocompromised patient.
Okay, so this question is, I think, for Dr. Baghdadi. Would neoadjuvant chemotherapy work for non-muscle invasive upper tract urothelial carcinoma? And if it is a muscle invasive, what precautions do you take to avoid urothelic injury or excessive bleeding during biopsy?
I wouldn't take a biopsy for muscle invasive. Even technicality is difficult to take it. Just I would take the biopsy. If it's high grade, I will consider it high grade because the stagings in the upper TCC is irrelevance in the and this difficulty of technical difficulty. Just as I said, we surrogating the stage, the grade for a stage. So if I could resect it, I could resect it, but I wouldn't exaggerate to take all of the until the muscle, as we know, technically is difficult to resect all of the tumor. The precautions, just if the high stage, as we we categorize in the scheme, or as we put it in the scheme, it's more than 2 centimeter multifocality. And nowadays they have a nomograms. I didn't speak about the nomogram. The nomogram, they try to provide a good system for staging. They use the grade, they use the architectures, they use a lot of clinical stage through the CT scan. This nomograms is not much sensitive and specific, but at least just we have to develop some modality to overcome the poor clinical staging.
Okay, question for Dr. Alkhateeb. For BCG hypersensitive patients, can we give smaller doses?
Well, that is a very good question. Yes, and it's been tested, and there are large trial about reducing BCG dose that showed the same efficacy. But usually for those BCG intolerant patient, even reducing the BCG dose will result into the same side effect, but you still can reduce it 50% or even 1/3 of the usual dose and give it a try. If they can tolerate it, that's good and fine, and you should expect the same or almost the same result as a full dose. But if they do not tolerate the full dose, the likelihood of tolerating a reduced dose is low. But it's still, yes, you can use 1/3 or.
Okay, question to me from Abdullah Al-Anizi regarding Montigel. When it solidifies, is there risk for hydronephrosis obstruction? So I forgot, seems to be to say that mostly all of the gel will liquefy after 6 hours and it will be drained out. So it only stay there for a few hours, and by 6 hours, all of it will be liquefied. So the risk of hydronephrosis obstruction is not high. Is there any local study in KSA about BCG? To my knowledge, I don't think so. Sultan, do you know any?
Sorry, what was the question again?
Any local study about BCG?
About what in BCG exactly?
About BCG installment in bladders.
I'm not aware of local. I was part of multiple publications, and we used some of our local data in BCG in elderly patient population. That is published Journal of Urology that showed a less effect in older patient. But pure local study BCG, no, I'm not aware of.
Okay. So there is a question to me from Dr. Ahmed Al-Hadi. Do we need ureteroscopy before nephrectomy? I think yes. So you see a filling defect on CTU. You do cystoscopy. You look around in the bladder carefully with 30 and 70, or you have 110 degrees lens. You look in the prostatic urethra and other places. If you see any suspicious areas, you're gonna biopsy. So you take wash from the bladder. Then you do your put your ureteric catheter in the lower ureter only, without trying to do that without guide wire. And then you do take a drip from that ureteric catheter, and then I put like 10 cc's to 15 cc's there after taking the drip, and I inject them, and I wait also for that to come down and to collect that wash. And then I go with, I do retrograde pallogram and locate where is that tumor. I go with my ureteroscope. If it is ureteric, I go with rigid. If it's flexible, I go with the flexible. If it is upper tract, I go with the flexible. And I do that. I try my best to do that without guide wire. It's possible. And if you need to put a guide wire, only put it in areas that you can see with your ureteroscope. And I think that you must see it. Biopsy is very essential, especially if it is low grade. And mostly these patients, if their CT doesn't show invasion, mostly 80% of low grades are non-muscle invasive. So kidney sparing can be done. The cost of Matogel, I don't know yet. It's just got if they approved, and actually didn't arrive to Saudi Arabia yet. There's a company that called Teba, I think. They are looking into taking that medication. Does BCG vaccine reduce hypersensitivity of BCG intravesical immunotherapy? That's to you, Sultan.
I was reading another question, which is, if you may allow me to answer, which is regarding your opinion about the use of gemcitabine in intermediate and high risk patients. I personally do not have an experience in using gemcitabine. I don't know if the other panelists or any of the audience have the experience.
So we have experience. We have been using gemcitabine for the last 2 years during the BCG shortage, and actually now we use this. We use it for all tumors, all low-grade tumors. Also, we stopped using mitomycin C all because gemcitabine is cheaper and also less side effect and irritation to the patients. And you don't see those calcified areas in the follow-up. With mitomycin, you see all of the areas that had that calcific reaction. You don't see that with the gemcitabine. For high grade, in the times that we don't have BCG, gemcitabine had shown that it is as good maybe for recurrences, but not as good, of course, for progression.
And the other thing, a follow-up for the question regarding any local publication regarding BCG, Dr. Ahmed Zahrani from Prince Sultan Military Medical Complex just sent a follow-up that they presented an abstract in one of these SUA meetings about rare complication of BCG, like peritonitis, osteomyelitis, or some other. But I don't know whether this was published or not. But I mean, this is just for everyone to know about.
Okay. What about this BCG vaccine? Can it reduce the hypersensitivity of BCG intravesical immunotherapy?
No. No, this was proposed, and it's been shown that it has no effect on the BCG response.
Okay, a question I think to all of us: in case of distal uretrectomy, do we need to take a bladder cuff?
In case of upper tract, you mean? I answered this question.
No, distal uretrectomy. In case of distal uretrectomy. So you are doing kidney sparing surgery for low grade or high grade lower ureter tumor, and you did the distal uretrectomy. do we need to take a bladder cuff with that? Sultan?
I believe taking a bladder cuff is an essential, yes, okay, because the idea here is that even if the distal ureter and the intramural ureter is free of tumor, and you're gonna do a distal uretrectomy and reimplant your ureter, the remaining part that you leave behind will be very difficult to follow up. It is at risk of having a metachronous tumor, and it will be very challenging to go and do a surveillance cystoscopy or even ureteroscopy for this small stump, which has a risk of so removing the entire ureter with the cuff of the bladder, it's done because of the risk of having a metachronous tumor within this. So yes, it is always important to remove it, even if you have you're doing a nephrectomy for a renal pelvis or an upper caliceal tumor. Yes, you have to remove the bladder cuff for this reason.
Okay. For our high grades, I always also give neoadjuvant and dual lymphadenectomy. Mohammed, I think it does the same. What about Sultan? Sultan, do you give neoadjuvant and do lymphadenectomy?
Based on the new evidence, yes, we do. Okay. The challenging thing here with the neoadjuvant issue is the yield of biopsy. We always have this discussion in our tumor board. Commonly diagnose upper tract TCC based on imaging and ureteroscopy finding. It's very rarely that you will have a positive pathology. And our colleagues in medical oncology, they are sometimes hesitant to give a neoadjuvant chemotherapy. But if you want to follow the new standard of care, yes, you have to give a neoadjuvant, and yes, you have to do lymphadenectomy.
Okay, last, I think, couple of questions. How significant is the effect of neoadjuvant chemo in the performance status and the timing of surgery? That's the question to Mohammed, I think. Mohammed, can you turn on your mic, please?
I answered this question before, but as I said, there is no impact on the timing of surgery. There are no single one case progress in all of the entire retrospective and prospective trials. First of all, the impact of life, as I said, most of the patients, if we didn't give them the neoadjuvant chemotherapy, they will lose the eligibility for cisplatin. So I prefer to give neoadjuvant chemotherapy, and the performance as the oncological outcomes is with the data is promising. It down stagings, and even give some data to show there is overall survival or disease recurrence rate. Disease recurrence is better. So all of the data support to encouraging give a neoadjuvant chemotherapy.
And the last question was from Abdullah Anizi to Sultan. We know that single dose mitomycin reduce recurrences, but is there a strong evidence for maintenance mitomycin to prevent recurrence?
We have to understand here that I did not talk about single dose mitomycin in my presentation, yes, because single dose mitomycin is a different subject than when we talk about BCG refractory disease. Single dose mitomycin is given only after the first time TURBT, and it's given before you know your pathology and before you risk stratify your patient. It is the standard of care. It's known to decrease the recurrence, okay, but it has absolutely no value in patient with intermediate and high-risk disease who received BCG and who had a recurrence later on or a refractory disease. So that's one point that has to be made clear. Now, when you have to give mitomycin for BCG refractory disease, it's given as 6 doses mitomycin, whether alone or with the device-assisted techniques that I've mentioned in my presentation.
Yeah. So I think that's conclude our virtual club. We are really thankful to our audience. Special thanks to Adil Ammari and to our speakers, Dr. Mohammed Albaghdadi and Dr. Sultan Alkhateeb, which both of them did a marvelous job in updating us. Thanks a lot, and hopefully we'll see you next month.
Thank you very much. If you may allow me to add one thing for those questions that we were not able to answer for the sake of time, please feel free to contact any one of us through email or messages or through the group, the SUA WhatsApp group, and we'll be happy to answer any questions and to share any thoughts or comments or feedbacks.
And we're going to start also a WhatsApp group for the Urooncology group that can be joined by any SUA active member who is interested in oncology and who practices oncology. Please, in the SUA active members group, if you are interested in joining this group, send your request, and next week, inshallah, we'll form that WhatsApp group for the oncology interested people, and we can discuss all questions, cases, and updates all together. Thanks a lot, and have a good night.
Thank you so much.